All right. Good afternoon, almost evening, and welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We're here today to hopefully complete our work on Health Bill 601. I always think optimistically. Bring a reprint that is the result of the discussion that we had this morning. Lisa is going to go through the reprint, the changes in the reprint. We will have a discussion of the changes, and then if we can find our way forward here, I would like to consider voting on this bill this evening. And I know that we are time because it is late on a Friday afternoon. I hate to rush this, but we have gone through some of it. There's been a lot of collaboration between the Maryland Insurance Administration and the representatives of PBMs and carriers. So I'm hoping that that collaboration has gotten us to a product that, while it may not be comfortable for everyone, at least it can be considered for moving forward. Given that, Lisa, I'm going to let you start and tell us what's different in this reprint that came out at 4:30 today.
Yep. So the first change is on page 1, and that is excluding ERISA plans from the definition of carrier. On page 4, we're specifying in the definition of purchaser that it includes carrier. On page 5, we removed from the bill language section 15-1612. On page 6 of the reprint, we changed in the credentialing requirement the reference to the PBM's network for a carrier. And that last page of the bill in the uncodified language, it provides for the application of the act to contracts between a PBM and a purchaser that is a health and welfare benefit plan on the first day of the first plan year beginning on or after January 1st, 2022.
Okay. Questions, concerns? It sounds to me like in at least a couple of places we were able to respond to PCMA's concerns, likely raised another. So let me pull up my participants. And I've got Mike first. Mike Johansson.
Thank you, Madam Chair. Mike Johansson on behalf of PCMA. Yes, thank you. We were able to, I think, agree to some applicability language that would seem to make sense. These aren't just insurance companies, they're different kind of plans. So I think the reference to health welfare benefit plan, it makes sense. We appreciate MIA kind of taking the lead on that drafting. They also agreed to the language to modify the definition of carrier to exclude the certain ERISA exempt plans in that section, which just maintains the same definition of carrier that we have today, which used to be called purchaser, now it's called carrier. But we do note now by deleting the reference to 15-16-12 in the bill, that means the way this reverse bill is working, we are subjecting ERISA plans and local government plans to the limitations of 15-16-12, which relates to reimbursement by a PBM of pharmacies may not be in an amount less than the PBM reimburses an affiliate. This is a provision that had a little bit of discussion this morning, but not extensive. This is a provision, while it screens rates, it also is a network development provision. It is much different than MAC pricing limitation, GER, the direct things that we recognize Rutledge was about. And honestly, we feel this is the type of provision that is going to lead to significant review by the plans that are now subject to it, and whether that's legal review or just opposition. But certainly, you know, we started with a concept of narrow, and it continues to grow. And honestly, we would ask and recommend that in order to kind of keep this package narrow and preserve some of these more complex conversations that we all know we're going to have over the interim. And I think we're going to do it in a much more informed and thoughtful way, seeing how other states respond as well. I think this is the type of provision we would ask you not to include at this time.
So you're asking that 15, 16, 12 be reinstated in this?
Reinserted in the bill,
Reinserted.
which would have the effect of it only applying to the carrier definition, which is current law, and not expanding it to the broader set of purchasers. You know, this provision is, you know, somewhat targeted to begin with. There's very few, or perhaps one, PBM that actually has affiliated chain pharmacies. So it really kind of seems a much targeted provision to begin with.
Okay. All right. Thanks. Delegate Kipke.
Thank you, Madam Chairman. Actually, Mike, the bill started out very broadly, not very narrow. So we've from a very, very broad bill to a very, very narrow bill. But can you, as you said, this screams reimbursement. How using that logic, how is this any different? If you're saying it has to do with plan design, which is what we can't go near, how is this any different than GER or MAC?
Well, in my view, GER MAC is broadly applied, right? It is broadly applied to all the participating contracting pharmacies. The way I think the GER, you know, by recollection, the way the GER provision says, a PBM may not have a GER program that has retroactive reimbursement across its entire continuum. Here, this is an actual rate provision related to, in a sense, certain pharmacies versus other certain pharmacies. We think there's a distinction there, and I think our PCMA council would agree. And yes, we acknowledge it was a very broad bill. It has gotten narrower, and then now it's getting broader. We understand where we shifted, but I do recognize, and you said this the other day, it was broad but only applied to ERISA. Now it's narrow but applies to ERISA and local governments, and I understand that was your intention all along. But so it was broad but narrow, and now it's narrow and broad. So
An accordion, a little bit, a little accordion. Van, I'm wondering if you have thoughts on this. Where is Van?
Yeah, I'm here.
There you are. Okay.
You know, the MI is not taking a position with regard to this issue. So, you know, we've tried to stay to provide technical assistance.
Okay. So I want to ask, probably I'm going to ask Delegate Kipke's question again, but let me see if I am understanding complication. So the 1612 refers to the rate reimbursement for, and how it can't be different between an independent pharmacy and chain pharmacies that are affiliated with a carrier. Am I right on that? So
kind of.
equal.
Right, I think that's the first part.
Okay.
However, it also says that the section doesn't apply to chains with more than 15 stores. So for example, just to pick out names, I don't know anybody's pricing. So let's assume Walmart has more than 15 stores in the state of Maryland. It's probably a good guess. So this provision wouldn't say that a PBM can't pay its own affiliated stores more than Walmart. It actually would allow that. It says it can't pay independents less than its affiliated stores. So here's a provision that is a specific kind of Maryland law that was designed with this number, and it could interfere with someone's network strategy of what type of independents and how many that it wants, how many chain stores it wants. Suppose it's a chain store that actually only has 10 in the state, but is actually part of a large national contract. I think we could see that, for example, you could only have 10 Weis supermarkets, for example, in the state, but there's 50 across the country. It's part of a large national contract. And in Maryland, Weis could not agree to a price that was less than what they were paying the affiliated in Maryland. But in the other states, it has its 40 stores, that limitation wouldn't apply. So it has a peculiar provision because of its specificity with that number that could affect your network development. It could affect your contracting in other states, which is kind of precisely with ERISA plans, we understand that they can have multi-state focus. So that's why it makes it a little bit more difficult. And honestly, it's kind of such a complex provision and has these certain provisions. It doesn't apply to specialty. It doesn't apply to mail order drugs. I just think it's more confusion than we had this morning.
And so are you suggesting that this provision, because those chains would have states across lines, that the networks would be across state lines?
Sure, right? Because we're talking, if it's an ERISA plan, let's start with that. So it's Under Armour, and they have stores in Pennsylvania as well as Maryland, and it's one health plan. It's ERISA exempt. It's self-funded. If they're contracting with a PBM, they may be contracting with the supermarkets that operate in Maryland and Pennsylvania. And this language, 15 stores, may interfere with their pricing strategies and whether or not to even include a certain supermarket chain, because if they had less than 15, they would have to pay them perhaps more than they were willing to pay them. But if it's a grocery chain with 15 in Maryland, they could pay them what they were thought they were going to pay them, which could be less than they're paying someone else. So I think it is more than price regulation related to, like GER and MAC, as we talked.
Mm-hmm.
Those were across the board. It wasn't limited to different sizes of your pharmacy network.
Would this language affect the purchaser's ability to have contracts in other states? Would it say, because the Maryland law says you are required to reimburse your your contractees rather at the same rate as yourself? Does it apply outside of Maryland, or would it only apply inside of Maryland?
I'm going to dial for a lifeline. I don't know if Kim's on, or Kathleen, or Heather.
Heather's here.
Would it control the rate that you pay in Pennsylvania if it's a grocery chain that has stores across the line?
Unfortunately, I don't know the answer to your question, Chair. I'd have to ask. I honestly don't know how far that would apply. But to Mike's earlier point, I think the differentiation we're trying to make is the difference between the level of reimbursement, of the level of the rate in question to a given participating network pharmacy versus who can participate, like the actual development and building of the network. And I think that's kind of the differentiation we're trying to make. But sorry, I can't answer your question directly about whether it would affect in state or not.
So the concern is, and again, I think I'm probably just restating, but just again, to make sure that it's clear in everyone's head. Your concern is that their plan design could potentially change. Those who serve ERISA and self-funded plans, their plan design could change in the development of their network based on this language. Is that what you're saying?
I think it affects the network strategy, which is who you include or don't include and it will affect them in a way that they weren't affected before, right? And the question is whether someone would bring an ERISA exemption claim because of this particular provision. It's clearly, I don't think this was referenced in the Rutledge decision like the others were. And, so again, Madam Chair, I think it raises to more of a level of complexity. And I think, all we're asking is that we have time to consider this as part of whatever's coming next year. And I think we all know there's going to be a healthy conversation. All we're asking, if this bill moves forward, it moves forward without this provision being applied to ERISA plans and government plans.
Okay. Members of the committee, Delegate Krebs.
Thank you. Well, as we know, ERISA plans and government plans are a huge part of the market. And sometimes when we're talking about this issue, I think it's really simple, and then you make it really complicated. And every time we've sat here year after year after year after year after year after year, somebody says, let's just wait until next year. Let's just wait until next year. And we lose more and more independent pharmacies. So again, sometimes I think it's a simple question. All we want is a level playing field so that our independent pharmacies are able to compete and have a prescription at a price the same as the other folks. It's sort of simple, so they can compete, so we can have local pharmacies. And then we get into all this plan design and ERISA, and we get real complicated again. How do we get what our goal is just to give these guys a chance to compete at a level playing field? How do we simplify this and not wait? I've heard next year so many times, and it's just a way to put off, and we put this off for years and years and years. So I don't know the answer because this is complicated the way we write this stuff, but it's just, that's what our goal is.
No, I appreciate it. We haven't put this question off,
Right?
because until the Supreme Court decision, this was thought by many states something you couldn't do. Okay.
No, but the end goal of what we're trying to get to is sort of the same. It's just now we have a little more tools in our toolbox to be able to do that.
But in every, as you know, more, I think, than most, every issue is a trade-off of the goal you're trying to get to and the goal that you're not trying to hurt people that are actually paying for the healthcare, right? So this affects employers, ERISA plans who weren't previously subject to this. Now they will be. It could have a cost on them and their employees. It'll have an impact perhaps on local governments and the people that pay those health plan costs. So it's a balance. We understand the goal to help the independent pharmacies. Okay.
And I don't understand how letting someone else sell a product for the same price is going to hurt their health plan. I sort of don't understand it.
This prohibits paying someone less than something else. Okay.
Right.
So by definition, it could mean you're going to be forced to pay more. So that if you're the payer and you're responsible for it, some would see that as a negative impact, right?
I'm not going to say right. I'll say I hear you.
I agree. I mean,
So I think just one, and I'm Mr. Ken, I see your hand. I just want to say, so one potential risk here, if I'm understanding, is that the chain. So if Walmart is the PBM, and Walmart contracts with the PBM, right? And so then they, if they want to contract with, let's talk about independent pharmacists in Maryland. So if it's Walmart, rural Maryland, Western Maryland, Eastern Shore, might be fewer chains, might be more independent, or at least some independents. Are we at risk of them saying, because I have to pay them, more, I'm not going to contract with them, with the independents? Is that what I hear you saying?
I think that's an additional risk, certainly. I mean, for most terms of network adequacy, it's not often the case, except in very rural areas, where in order to meet a plan sponsor's network adequacy requirement, you would need every independent. I think we would all agree, and Kathleen, you're probably the most knowledgeable about network adequacy. You don't need every independent pharmacy. You certainly don't need the independent pharmacies for network adequacy in the central part of the state, especially
Right.
all of them, right? So,
Right.
so if this provision is applied to purchasers that it hasn't been applied to before, could there be some impact? It's theoretical. You know, it's hard for me to say that they wouldn't still try and contract with them.
Okay. Okay.
Yeah. So I would
David?
agree with Mike's statement.
Kathleen, hold on just a second. I want to go to
Absolutely.
David, you're on mute.
Okay. Well, I think as has been pointed out, this is primarily a policy decision.
Mhm.
I just want to revert back to the point I made this morning, which is that the Rutledge decision, in our view, is not as narrow as PCMA has been arguing. It doesn't clearly only apply to MAC pricing. There's an interpretation that it is much broader, and Section 1612 directly relates to reimbursement and simply says that a very large PBM that also owns its own pharmacies can't pay its pharmacies more than it pays other pharmacies, and therefore, attempt to tie its PBM services to its independent pharmacies and create monopolies. And that's the purpose of 1612 as well as 1611.1, which we're not dealing with here this time. So that's, if anything, from a policy point of view, it seems to me that the bill 1612 should be changed so that the PBM has to pay all pharmacies, whether they're larger chains or independents, at the same rate that they pay their own affiliate.
Okay. Kathleen.
Yes, thank you. I really just wanted to say I agreed with Mike's assessment, and keep in mind that this provision that's in play today will continue to be applicable as it is today if you leave it as is, right, in the bill. If you take it out and you are applying it now to entities that have not been subject to any of these provisions, you run the risk of cooling the market or having an adverse outcome when you don't need to do that at this time. And a fuller discussion will give you the benefit of that at a later date, of understanding the marketplace impact, particularly as it relates to these ERISA plans and the county governments. I don't know what the impact is to those entities, particularly county governments, and their ability to work under this provision, because they haven't had to do that yet. And I don't know what constraints there may be with their own budgets and their own networks.
Debbie, I'm going to call on you for a second. I'm not sure you can respond, but in terms of thinking of network adequacy from a carrier's perspective and plan development, would having this language, what impact could you potentially see from your perspective as a carrier? Or, if Matt or Kim can speak to it as well, but I'm trying to get at all perspectives here.
So I really don't have any sense whether this would impact networks, but I can tell you we're very concerned to make sure we do have as broad a network as possible throughout the state for pharmacies. We are very committed to having small independent pharmacies as well as the larger chains. We really look at a small portion, segment, depending on where you live, to try to make sure that there are a certain amount of pharmacies within a 1 mile radius, a 2 mile radius. We really focus on really ensuring that there's access for all. So I can tell you that making sure we have enough is extremely important. Will this impact the network? That I have no idea.
Okay. Any other
No.
words of wisdom here?
Where's my camera?
There you go.
So, hi, Madam Chair. I think the challenge that I've had with this provision is similar to what Mike has shared, just because it is not the same traditional approach at the rate regulation, the same way the MAT or the GER takes it. I do wear two hats. I work for a company that is both a carrier on one side and a PBM on the other. So putting my carrier hat on to answer your question, carriers are always, as Ms. Rifkin said, very sensitive to the networks that we're trying to build for our members. And what's always been a little bit challenging with some of these provisions for me is that we negotiate rates with all kinds of chains of various sorts, with various providers across all kinds of specialties. And the reality is there's no space in healthcare where everyone gets paid the same rate. And so I think, I understand the vision of the world where everybody gets paid the same rate, but we don't live in a healthcare system where that's financially feasible for patients, or the way network plans are built. They're designed to be focused on making sure that, part of the trade-off with providers across specialties is you get the trade-off of, I'll take less reimbursement to have you drive business my way. There's a lot of different considerations that providers make about the reimbursement they're willing to take. And, I know this was aimed at a particular company, who this provision really hits. But I do think that it has the potential to have impact on network design. I don't know how it fits with Rutledge. It's not as clean a fit with Rutledge as the other provisions that you're considering in this bill. And so it's not one that I even inquired about, because until this version, it was not on the table. And so I haven't focused on it to really have a deeper investigation or gotten advice from counsel. So those are a lot of rambling thoughts, because it is a more complex provision for my mind than some of the others.
Okay. All right, so we have, as I think Mr. Can said pretty clearly, it's a policy decision here. We can take the risk that this is going to put us in that fine line around the potential to be called into question with respect to plan design and benefit, or we can say, so we want to take that risk, or we can say there's, we can have the opportunity to study it over the summer and look at potential impacts, because we know we're going to be looking at this further. Delegate Kipke.
To David or Dennis or any of the others that can respond, the arguments being made that this provision could harm independents being included in networks, do you have any concerns about that? I mean, my thought is if we were to adopt this and add some type of severability clause, we would probably be okay, but there's an argument that's being made that having local governments included in this now could somehow squeeze. I'm not seeing it, but I want to verify it.
Well, I was just to be clear, Delegate, I was just worried, given that when Mike said it might, PBMs might reconsider their networks based on what to pay. And I don't want to shut anybody out, just basically.
Yeah, I heard you loud and clear.
That's what raised the question for me.
Yeah, have you all, have you had time to consider that?
Anyone?
David? Dennis?
I have not had time to consider it. I was looking at it purely from the perspective of the Rutledge decision and reimbursement.
Well, let me just say, if we can get Mr. Enton to agree to support the bill, I'd be willing to
I
leave.
know I shouldn't have put my video on.
I was just thinking how nice it was to see you, Bob.
You finally appeared.
Tell you, Kipke, did you buy that bottle of scotch for me yet?
Wait a minute. I need to hear Delegate Kipke finish his sentence.
Yeah, so let's let the MIA study this so that we don't have to worry about any network issues for the people that we're trying to help. I think it is probably unlikely, but you know, at this hour, I think it's probably the better way to go. So,
Right.
you're all right with that, Chairman?
I am all right with it. I guess, like I said, my concern came up when I thought, oh, wait a minute, there could be a negative consequence here I hadn't considered. So what I'm hearing is, let me ask, is there, do I have an amendment that would
Madam Chair, I moved.
reinstate
Yeah, I moved
1612?
to. Yeah, I moved to do that.
Do I have a second?
I'll second it, but I didn't hear what he said. I'll second it, but I didn't.
To maintain the
You're
status quo.
following blindly. Yeah, to maintain the status quo for now, Sue.
on
On
just
that
the-
piece.
No parts of this bill at all.
No, just that part. Yeah,
That's just that part. Everything else we'll
Yes.
take with that one piece.
right.
Right.
I'm going on your
Anyone-
best judgment.
Okay, Delegate Bandari, do you have a question or are you voting against the amendment?
Oh, okay. I just have a comment, you know.
About this amendment?
Yes.
Okay,
Yeah, yeah, if I heard correctly, Ms. Robinson said that there might be the impact on network design, and we don't know the consequences. If we could put some study language on it, so we could find it as well, rather than just going with the status quo. Just the comment.
I think Delegate you would be open to that, wouldn't
Yeah,
you?
I think, yeah, there is study language already in the bill. to
Right.
look at everything. No,
Right.
There was
Is it-
study language in a version of the bill. There isn't currently, but
Oh.
that could be put
Can
back
we
in.
put back
Yeah.
in before
Yep.
voting session? Okay. All right, so let me ask, those in favor of the amendment to reinstate 15, 16, 12, say aye. Those opposed, please raise your hand in the participant panel. Okay, not seeing any hands, the amendment passes unanimously. Are we ready to move the amendments?
move the amendments.
Second.
Okay, anybody want to discuss the amendments further? Seeing no hands, those in favor of the amendments, please say aye. Those opposed to the amendments, please raise your hand in the participant panel. Seeing no hands, okay, the amendments pass unanimously. Can I have a motion on the bill?
Move the bill.
We're tired.
Second.
Okay, I've got a motion and second. Any further discussion? Okay, seeing none, those in favor say aye. Those opposed, hands in the panel. Seeing no hands, the bill passes unanimously. I want to thank you all very, very much for working through this. And I look forward to us digging a little deeper over the course of the next year and figuring out what the opportunities and options are. Thank you all. That concludes our meeting for this afternoon. And for many of you, I'll see you tomorrow. And for some of you, I'll see you in about 5 minutes.
Thank you.
Thank you.
Thank you.
Thank
Thank you, Delegate Kipke.